Section 5. Again, I hope this video finds you all doing well. Week 6 wrap up: ankle and foot disorders, Achilles tendinopathy, and plantar foot pain or heel pain. Got a lot of good stuff this week. Again, some really good discussions in some different groups. I don't have time to hit all the points. I'm going to miss a lot of stuff because I want to keep this at 10 minutes, but really good information and good discussions. So just quickly, weekly readings, the Minkin presentation on manual therapy and foot disorders. He's right. There's not a ton of great stuff, but there is some stuff. And I don't think we should just we shouldn't obviously abandon manual therapy in relationship to the foot, but I definitely think we need to be more critical of its use at certain junctures. That's why we use our clinical decision-making and reasoning as we follow the best available evidence. Minkin does say that there is some manual therapy to support it with ankle sprains, and we're going to do more on that next week. A good chunk of a whole half of his presentation was dedicated to ankle sprains. Heel pain, the three biggies: increased 30 BMI, decreased dorsiflexion, and prolonged standing. Cleveland study, which we'll talk about kind of coming up, demonstrated manual therapy effectiveness with the meeting of the MCID and also the number to treat of 4. However, this was not included in the review in the clinical guidelines that JOSPT presented. And it's just one study. It's a good study, and it showed effects, and we'll talk about that more, but it was just one study. Cuboid syndrome, thrust manipulation with case series. So the cuboid whip, hopefully you guys got an opportunity to do that at your weekend intensive. Hallux rigidus showed again with the case series some joint mobilizations to the great toe and its importance. And then Morton's neuroma. Sample size was very small, and obviously, but manual therapy wins out in their comparison group. And I will say that I've treated all of these things a number of different occasions, and I am always surprised at what we can offer. Usually they're in conjunction with other things. Rarely do I see just a neuroma in kind of independent of itself as people just come in, or hallux rigidus, but oftentimes in using kind of a regional interdependence approach, you end up finding out that, hey, they've got this kind of I had a woman tell me just last week she had plantar fasciitis and it was acting up again, and she pointed to the outside of her foot. I manipped her cuboid at one visit, and which I was treating her knee, opposite side knee, and then it was gone in a visit. Her pain was completely resolved. So very effective treatments with the right patients. However, the summary of manual therapy for ankle and foot disorders, I thought this slide that he posted, man, it was spot on. Poor to moderate quality evidence for the use of manual therapy. Manual therapy should be used in complement with other things. We can't just rely on it. You can pretty much manip a neck or a low back sometimes and give people reason to believe that may be all that needs to be done, even though we know there's more to it. So again, consider our regional interdependence. If there is an impaired joint mobility, assess, treat, and reassess. As Tim Flynn always says, move it and move on. So in the Cook study, or in the Cook kind of review, if you will, of Achilles tendinopathy, which is really a good one, kind of one of those, in my opinion, you just keep and you refer back to. I like that he said that aging is not a sign of tendinopathy. And that's really important because it is a degenerative process that we find it to be. However, it's not like a degenerative disc disease or degenerative joint disease, which we would consider a natural part of aging. This is part of a trauma, typically, or an overuse. Morning pain is a hallmark sign, again, something to be aware of. Rest can have negative effects on tendon healing. Very important. These people, we don't tell them to go home and do nothing, even though we know that physicians do that, and we know that they think that's what they knew. That's why they need to understand what this problem really is and how loading the tendon is really important. Rest can have a negative effect on tendon healing. Eccentric rehabilitation is the gold standard. Obviously, we get into more of that with the other research as we continue to pound that eccentric. And tendon pain is a part of a failed healing process. And that gets back to that whole degenerative thing. This abnormal scar tissue that lays down in ways that just do not afford mobility. I always use this example with my patients. I use the example of a cut on a knuckle versus a cut on just on a smooth piece of skin that's not related to a joint. That knuckle, every time it bends, it scars down in ways that starts to model that healing process, but it still will take a lot longer for you to afford the mobility of the bending of the knuckle if that tissue doesn't allow for that, and it just takes longer. And every time you bend it, you get a little bleeding, you get a little more scarring, but eventually it models in a way. Well, I use that example as far as tissue healing, and then I correlate that with this kind of tendinopathy pain, whether that's in a patellar tendon or that's in the Achilles tendon or what have you. And I think it works pretty well. Most people catch on to that, or they're just simply placating to me and saying, "Oh yeah, I get that." Weekly reading. So again, in the Cleveland article, manual therapy versus traditional PT modalities. This kind of an article was really poking the bear. It was going at those PTs who don't use manual therapy, and the point was that we can do better than just putting some machine on somebody and not doing anything impactful, not again using our hands, our skilled clinical reasoning, our skills, our manual therapy skills, our motor skills to help get people better. He kind of coined the phrase plantar heel pain as opposed to plantar fasciitis. He used a regional interdependent approach which focused on hip, knee, and ankle versus ionto, ultrasound, and stretching. So just think about where that was. It was as much a clinical commentary to our profession, who was still using 80s and 90s kind of treatment techniques to challenge people. The number needed to treat with 4, and hopefully all of you know that so you need 4 people to treat before you'll see progress with 1, and anything less than 10 in a study is usually really solid, or 7. 4 is pretty darn good. The Grok showed moderately better. The MCID was significant. It wasn't a huge home run, but it definitely showed that there was potential. I think that's really what it said, and it also said, put the machines away because they have limited value. One of the in the other heel pain presentation, this slide in my mind was really good because it really the DiGiovanni study that looked at chronic plantar fasciitis and this stretch. I think if you're not using this stretch as a way of helping patients get better, you may be doing them a disservice. That article was pretty solid, and it's something that you should really be thinking about with plantar fascia or heel pain. I think that this was one of the more highly recommended treatments, and so I like this slide and kind of really summarized my thoughts on, or one of the more effective treatment techniques that we have, especially for someone to go home and be able to do that. Points of conversation. So there were some really good discussions in a couple of different groups. Alicia Halley and Casey engaged in an interesting discussion about eccentric exercise pain, compliance, athletes versus non-athletes. Throughout the threads, there was a general tone of, well, if it hurts, how much do you push? Some people can't push, and I think that that's very true. Some people can't push. But the one thing that we do know is if people understand that they're not causing harm to themselves, they're much more willing to deal with the pain knowing what they're doing. So if they have a firm understanding of what tendinopathy is and that it's not an inflammatory response, we calm the brain down, we take away the fear avoidance behaviors, they're much more willing to tolerate the discomfort that they may have. And I would argue that then there are going to be those people, and there's no question about it, who don't like pain and who are pain adverse. And there was even a discussion about exercise compliance athlete versus non-athlete. And there was recently back in August, and I posted this to this group, that there was an article published in the New York Times Health section that talked about why athletes might be a little bit more tolerant of pain and willing to work in it, because it's generally, if you're a regular exerciser, you're going to have some levels of pain, and you understand what that's about, and that may be why athletes are more compliant versus non-athletes. That's purely conjecture, but I think we do know that if the brain understands that pain is part of the process, it's less likely to ramp it up, and that's just the whole pain science aspect. Both Mick and Ray they had some spot on comments about not having to work to excruciating pain, but to work to a point of tolerance. If it's sore and you can tolerate it, great. If not, you back off. Mick even said in the Alfredson article originally, they didn't want to get to the point of debilitating or excruciating pain, and I think some people commented that article led one to believe that they were just going to hurt, and I don't think that's what happened at all. I think that they were told that you may have some soreness, and we all deal with some soreness, and if you can deal with it, great, and if not, we back off. Corey, Justin, Joseph, Mick, and Jess all discussed the readings regarding eccentric exercise with and without splint and why the difference. I enjoyed that banter that took place. I thought it was very, very good. Some of it was purely speculative, but again, I don't care. I just enjoyed the banter. I enjoyed the engagement. Whether the splint made a huge difference in decreasing their pain, if that's really what it was, because you put them on prolonged stretch. We know stretch can have some effect on performance. That's why they certainly don't recommend it prior to athletic training, because we know not only does it not do anything to prevent injury, but it may also decrease the ability for the muscle to perform. I liked the banter. And the research did tend us to stay away from those kind of splinting behaviors. Lastly, Joseph, Katie, and Payal discussion about instrumentation-assisted soft tissue mobilization for foot and patient tolerance. So this kind of stuff certainly could be effective. We know that in the Cleveland article they talked about getting in there and spending some time on the Sura as well as in the plantar fascia, working those over. I think they used 5 minutes as a time a specific time limit, and we talked about, can patients tolerate this, and is this a good thing? And I would argue that, I used to think you had to get in there and dig pretty hard, but I've learned that, even light soft instruments guided, I don't use, I don't use the either of the groups of tools, the iStim or, well, the name escapes me now, I apologize. I use the edge tool that, if I'm going to use anything. Otherwise, I'll use my hands. But I've learned that sometimes, going in soft can be as effective, and then kind of progressing into the tissue tolerance. So as they get more accustomed to it, then you can be more aggressive. But you don't even need to do that. So I would argue that if they're having any kind of discomfort, just back off. There should be no bruising. Again, people should be comfortable, and it should be to their tolerance. But that this was a common thing, and people found it useful because it saved on their hands, and they didn't feel like they were going home hurting, and the tools can be effective. I think the best way to learn any kind of soft tissue techniques is through your hands, and then gradually incorporate more tools. I teach part of a section of soft tissue mobilization at the University of Minnesota, and the first thing that we start with is obviously with our hands, and get them to feel that. But I certainly bring in different objects, and I've everything from dog bones, rubber dog or Naugahyde dog bones to the edge can be things that people can use. All right. With that being said, we got to move on to week 7, ankle sprains, forefoot disorders, and post-surgical management. So we do know that there's manual therapy for ankle sprains based on that Minkin presentation. And so there's going to be some opportunities to discuss those. Group projects, man, you got to get those done by Sunday evening, okay? No ifs, ands, or buts, because we need to be able to go over them starting on Monday as a group interacting. So for those of you who got it in late, you better get going. That's all I can say. The rest of you shouldn't have too big of a deal. TAs and myself will be switching it up. I apologize. I went right to Bravo and Charlie. It's been kind of a busy week, and I just forgot that we were switching. But we'll switch now for week 7 and week 8. Again, I want to recommend you guys finish strong. We got 2 weeks left. If it's some really good dialogue, sometimes we start to trail off these last couple weeks. Please don't. Please continue to push hard. Again, if you have any questions, if there are any concerns about the group projects, please contact me. And I am going to AMP this week. I'll be there Thursday through Sunday. So if you're there, come find me. I'd love to visit with you. Love to put a name to a face. So. Hope you're all well. Great week. Continue to work hard as we move into week 7, and we'll see you guys all online.